Good evening, everybody. Welcome to this second session of 46 comprehensive course on echocardiography. We have with us Dr. Colonel S.K. Parasha, who has been the leading name of echocardiography, the man who created Indian Academy of Echocardiography in India, and he has got experience of more than 50 years in teaching and practicing echocardiography. We always call him the father of echo in India. He has been the past president of Indian Academy of Echocardiography, past president of Cardiological Society of India, and the co-editor or the editor-in-chief of the recently published book of Test Book of Echocardiography. Vast knowledge of experience and the art of teaching, which goes down to just basics. That's what his specialty is. With this few words, I will request Parasha sir. We always address him as we address Doppler with the D word. We always address Dr. Parasha with the name of Parasha sir. Talk on this particular topic of basics of Doppler of echocardiography, which is again a basic topic to begin with this clinical applications in echocardiography. Sir, it's all yours, and thank you very much.
Before we go to the topic, we welcome you to this online courses, which have got certain advantages and also some limitations. And we'll try to convert most of the limitations into your advantages. Now, to be very frank, there are two types of delegates we have been seeing for last many years. One who are really interested in this fascinating technology. They are really interested, and some who are actually more from a commercial point of view, whom we call a half-baked echocardiographers or so. Now, when you learn any new technology, you feel difficulty. You feel depressed after 1 or 2 lectures, but it is nothing like that. Once the same lectures are demonstrated to you, then you will be more comfortable. So the thing is that you cannot learn only by hearing lectures or by reading. You have to see and discuss, and then you will know better. So when you go back to your places, try to contact some center. You have got certain doubts. You could note down certain doubts. Go to those centers, get clearly the doubt, not that you go on only reading this and then forget till a live demonstration, then you'll forget everything. So that you can, whatever is not clear to you, you keep it in your mind or write something and then clarify with the person with whom you are trying to do an echo or so. So don't just confine yourself to the lectures, but you'll try to make it as simple as possible. And I think you can interrupt in between in case you want some clarifications, or because probably by the end of the talk you might be confused as to which questions to ask or so. So you must read anytime. You have to read and practice. You see a DM person, if he wants to do an angioplasty, he goes to some other center, does anything. He has seen lots of angios and angioplasty, but for doing it himself, he has to read and learn. So I think you must spend your time in this reading and writing, because I know the majority of you have not read for last many years. So you have to develop a habit of writing, of the reading or so. So as the topic says, the basics in Doppler. Now remember what lecture was given last time and the current lecture. They are interconnected and they form the basis or the foundation of the whole course. That is why we are giving a 1 week difference between the two lectures, so that you can remember what you have been taught in the previous. What we used to tell our candidates was that when you go back to your room or the house and there is no disturbance, lie down, close your eyes, and think how does a parasha and the long axis look like? What are the structures? When you are not clear, see the diagram in any book. Again, please go to the short axis apical view, 4-chamber, 3-chamber, 2-chamber, what do you see in them, and make a mental impression. So that will be more helpful to you rather than uh, just keeping it. So if up to my will be a very basic talk. As I said now, you know this Doppler is based on this Austrian physicist. The idea of showing this slide is that it is because the Doppler should always be written in capital. When you write the report, because it is the name of the person, and today we are sitting opposite each other mainly because of this person who died at the age of 50 but left a legacy behind him in the Doppler. He was an Austrian person. Now, some of the important mantras of echocardiography is always have a good clinical assessment. Don't be in a hurry to do the echo. For doing a clinical assessment, you do not need more than 1 or 2 minutes. Just put your stethoscope on the chest and see whether you hear any abnormal murmur or not. So a good, unless you have got a clinical assessment, you cannot see what you want to show or see there. Both of you should be comfortable. That means when I do my echo, I have always sit on the left side because I am more comfortable. Always attach an ECG tracing. Never do an echo without an ECG because you have to report that what it is. There are certain diseases where you have to report what is the heart rate, what is the rhythm, whether it is sinus or atrial fibrillation, timing of the cardiac cycle. Because to give you an example, for example, say this patient was sent from the ward to the echo room. The sister doesn't bother what is there, but you see the heart rate was only 35 and the patient was having 2 to 1 AV block. So we did a quick echo and sent the patient back before he develops any problem in the. So that is the advantage. And some of the advantage will show you again subsequently. So always do a tracing, record BP. Again, it doesn't take many centers. When they come into the echo lab, they have already got a blood pressure, height, weight, BSA, body surface area, with already written with them. Because the blood pressure has got a lot of significance in many of the Doppler studies. So these are hardly half a minute things, but you know it is very important. Important because you can get a lot of information. And as I told you, before the patient comes to you, let him have a height, weight, and the body surface area. This, why we follow this sequence, will tell you subsequently just now. So when the talk is over, you first start with a 2D echo, then go to the color flow mapping, then go to the Doppler. Always use a lot of imaging planes, both conventional and non-conventional, and never feel shy in mentioning the limitations of the study. Everybody feels a limitation. Imaging is very poor. You can't find any rejection fraction. Write it there. So use all means or so. And this has been told to you that the common views you take is a left parasternal view, apical view, subcostal view, suprasternal view. So these are the 4 standard views. And sometimes will be taught about the right parasternal view. And whenever you move a transducer, don't go on lifting the transducer repeatedly. The basis of the moving a transducer is sliding, angulation, and rotation. These are the 3 basic principles in transducer. You slide up and down, angulate this side, that side, till you get a good image and rotate. Now, this is an unconventional view. For example, it is difficult for you to see the large pleural effusion. And the pleural, these are floaters in between, and pleural effusion sort of a good conductor for the ultrasound waves, and you can see virtually a good subcostal view. And what you see, a subcostal view, you can see, but these are some of the unconventional views, so that you must know what you are seeing in a view. So that means the previous lecture was a very important one. Now, this we took with you to learn in first year and second year, but as I told you, by our experience of the previous batches, many of them did not know many things about this basic simple thing. So you pardon me if it is too basic for you, but I think because you have, and I'm very frank that many of you have not read for years. To follow this cardiology, remember one thing, that the inferior vena cava, the blue blood is the unoxygenated blood, red blood is the oxygenated blood. So the blood from the superior vena, inferior, sorry, from the superior and the inferior vena cava goes to the right atrium. You see, this is the right atrium which receives blood from the superior and inferior vena cava. From the right atrium, it goes to the right ventricle through the tricuspid wall. So you can see it goes to the right tricuspid wall, the wall which opens in diastole and closes in systole, because every ventricle fills in diastole. So the tricuspid wall has to open in diastole to fill the blood from the right atrium to the right ventricle. So this blood goes to the right ventricle, and then through the pulmonary wall, it goes to the pulmonary artery. And because it is an ejection of blood from the right ventricle, so they open in systole. So the atrioventricular walls open in diastole, close in systole, and the ventriculo-arterial walls close in diastole, open in systole. So this venous blood goes to the lungs and then goes to the pulmonary veins and goes to the left atrium. Now this is an oxygenated blood. It goes to the left ventricle through the mitral wall, which is again a left atrioventricular wall, which opens in diastole and closes in systole. And from the LV, it goes into the aorta through the aortic wall. So this is the normal hemodynamics. The main thing to tell you is the atrioventricular wall. Atrioventricular wall means between atrium and the ventricle. They open in diastole, close in systole, and the ventriculo-arterial it falls like a pulmonary and the aortic wall. They open in systole and close in diastole. So this is the normal pattern of blood flow in a person. So this is important to understand. Not that you don't know, but it is better to revise, and then we can understand better. Now, every chamber in the body undergoes systole and diastole, but unless it is specified, a systole and diastole are usually referred to ventricular systole and ventricular diastole. Unless somebody says atrial systole, atrial diastole, but if it is not specified, then a systole means ventricular systole when the blood is ejected out, and diastole when the blood is being filled in. So they are pertaining to the ventricles also. And preload and afterload, that will tell you. Preload is before what is known as end diastolic volume. Afterload is what the chamber faces at the time of contraction, that is afterload. See, left ventricular afterload, left ventricular preload, and then pressure overload and a volume overload. So we'll tell you, so this is very clear to you. We'll tell you they are all related to each other. So you see, a pressure overload is a state of a cardiac muscle which has to contract against an increased afterload. That means it has to contract. Now, suppose you are pushing a man of 50 kg or pushing a man of 90 kg, you require more force, more. That is afterload is that 90 kg man is the afterload. So it is a load against which the heart has to contract. For example, in left side, it is aortic stenosis, which is between the aorta and the left ventricle, or hypertension, and many other situations. On RV, it can be a pulmonary stenosis or a pulmonary hypertension. So these are the situations which would put and increase the load. So when there is a aortic stenosis, the left ventricle has to push blood through a narrow wall from the left ventricle to aorta, and because the valve is narrow, it has to increase its contraction. It is known. So it is afterload because it is after the ventricle contracts also. And volume overload is too large a volume of blood in a cardiac chamber. For example, high cardiac up again in the left side, aortic regurgitation or mitral regurgitation. In mitral regurgitation, the blood comes back from the LV to the LA during systole, and then goes to the and during diastole, the same blood plus the regurgitant blood goes into the left ventricle. So that left ventricle now contains the normal blood coming from the LA plus a regurgitant blood. So that is known as a volume overloading. Similarly, aortic regurgitation, the blood is coming from two sources, the mitral valve in diastole, aortic regurgitation diastole. So there is overloading of the ventricle, hence it is known as a volume overload. So these are the same thing happens at the RV side, like if any regurgitation or any sort of any increased load like a pulmonary stenosis or so. So these are the pressure overload and the volume overload. As I told you that anytime which is not clear, you can go on noting and then we'll tell you. Now this is only one slide of the physics because the physics of Doppler is very confusing. So we have never read it the physics ourselves, but only because you must have the sound emission occurs in cycles, in measurable frequencies in a second or so. So if there is one cycle is equal to 1 hertz. So now here you see there are 10 cycles. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So they are equal to 10 hertz. So when you hear millions of hertz transducer, that means it contains millions of cycles. So remember, one cycle is equal to 1 hertz or so. Beyond that, you don't worry too much of what is here. Now, ECG and echocardiac cycle. What is ECG systole? What is ECG diastole? Echo, now you see here. Again, very basic thing. This is a QRS complex and this is a T wave. So between the QRS complex and the T
Excuse me, sir,
wave
you are
is
not that
systole.
audible, sir.
I
Clearly.
can guarantee many of you would still and from a huh?
Sorry, sir, you are not
So
audible.
from a what audible?
Yeah, sir. Your voice is getting disturbed in the middle.
Audible तो होना चाहिए. Am I audible now?
Right now, you are audible, sir, but sometimes your voice does not come through.
Sir,
Maybe
The middle
because
of
of this. Maybe because of this problem or so. But this you can see. For
sir,
example, in this
sir, may
ECG.
I disturb in between, sir?
हाँ
There may be some other gadgets which are running on the same internet connection, sir.
Gadget is not. Hello. Let me
Okay,
check.
sir. It's fine, sir. Please go ahead.
Achha, for example, here you see from the QRS to the T wave is systole, and from the T wave this is the diastole. So this is how we see ECG, diastole, and systole. Now ECG and echo correlation. Now this has been told. Eh? This is mitral valve, as you know. Now mitral valve opens in diastole, as I told you, and after T wave it is diastole. And it closes in systole, as you see after the QRS complex, it closes in systole. So so this you can even, if you by mistake or something, your ECG is not there also. So the onset of the QRS opening is the diastole, and where it closes, it is the systole. So this is the ECG and echo systole. So this also will show you later on when you are more versed with the anatomy of this, of the structures. Now, whenever you do an echo, you must have three things, as I told you: clinical information by stethoscope, ECG, X-ray, anatomic information by 2D echo, hemodynamic information by Doppler. So these three are extremely interrelated and very important. I'll give you an example. I am bad in making slides, but my secretary is worse than me. Now see, this lady Aisha, 30 years female, Now ECG shows marked right axis deviation, marked right ventricular hypertrophy. So this is not normal for this lady, 30 years of female. And and when we did an echo, my diagnosis was a severe valvular pulmonary stenosis with an average gradient of 125 millimeters of mercury or so. So there was severe pulmonary stenosis. The same lady, Aisha, 30 years, went to a big medical college attached hospital, very premier cardiology center in Delhi, and they wrote a normal study. I think Dr. Gyan should change his name to Agyan. So you see, they never bothered to see the previous report. They never bothered to put a stethoscope. They never bothered to see what is the ECG like also, and they write a normal echo study. Same Aisha, 30 years. And then and the murmur was so prominent that one could hear it without the stethoscope by putting the ears on the chest. So then she was operated and found a severe pulmonary stenosis. So, so always what I say, always put a stethoscope. You will be benefited. We had one patient of a dilated cardiomyopathy, ultimately turned out to be patent ductus arteriosus. So, so always have a clinical. This is very important clinical information, anatomic by 2D, which have been told to you in the last exercise. And hemodynamic means hemo means blood, and dynamic is the pattern of blood flow. It is the backbone of cardiology, and it is a Doppler-based technique. It is that the invasive studies cannot be performed every day, but a Doppler-based technique can be performed several times a day, and gives the hemodynamic information. So clinical by ECG, X-ray, stethoscope, anatomical by 2D, what is the size of the chamber, what is the thickness of the chamber, what is the thickness of the walls, what are all these anatomical structures, and hemodynamics by Doppler-based technique. Now, what information does Doppler give and what does it record? Now you see, Doppler records a velocity and the direction of the flow. So this is converted into a hemodynamics. How will just now tell you. So the Doppler records the velocity of the blood flows into the system with a certain velocity. Blood flows in the system with a certain amount of direction. So the Doppler picks up the both, and this is converted to hemodynamics. How? This is known as a velocity are converted into gradients. In a rough language, a gradient means a difference of pressure between the two chambers. For example, suppose there is aortic stenosis. So there is a gradient between left ventricle and the aorta, because left ventricle pressure is increased. So the velocities are converted into gradients by 4 into velocity square. That is the formula. Now suppose the velocity is 3 meters per second. 3 into 3, 9 into 4 is equal to grade 36. Now, if your velocity is wrong, all your parameters will be wrong. So that means your aim is to get a maximum velocity from different scan planes. Because suppose you have recorded 2 meters, that becomes hardly 16. So misplaced it also. And suppose you have recorded 4, it becomes 64. So that recording of the velocity is the most important factor in the case of a Doppler echocardiography. And how do we record a maximum? We'll tell you shortly. And this is how it is converted to gradient. Again, a gradient is a difference of pressure between the two chambers. Now, for example, here you see this is a tricuspid regurgitation. We have put a Doppler here. It automatically converts into gradient. The velocity was 4.5 meters per second. 4 into velocity square comes to 122. So the machine itself converted into gradient, but your duty is to get a correct velocity, and you can get a gradients in this. Now, this is also important. There are something known as a Doppler shift or Doppler study. You can say there are 3 basic requirements for a Doppler: sound source, sound receiver, they must be moving towards one another. The traditional example always given is a whistling railway engine. Now, suppose you are standing on a railway platform. An engine comes towards you whistling. You hear a loud sound. That is because of change in frequency. As the engine passes off, the same velocity becomes, the pitch becomes less. So your source, and if both of you are standing on the platform, so then the railway engine whistle will be of the same intensity, same severity. It neither decreases, neither increases, but it is when it is moving towards you, and there are hundreds of examples every, whether it is a car, whether it is anything. So it is sound source, then the sound receiver is there, and then they must be moving towards each other. So these three things are required to get all basic information of the Doppler. So in a clinical echo, the sound source is the transducer, which has multiple crystals and multiple frequencies. Sound receiver, target receiver, instead of a human ear, are the multiple red blood cells or so. Because ultimately the Doppler goes into the velocities recorded of the RBCs and all the blood components or so. So sound source is transducer, red blood cells, magnitude of shift, that means how much it moves, is the velocity. So how the greater the when it is moving towards you, higher velocity also. So these three things are in a clinical Doppler, and when the flow is towards the transducer, it is above the baseline. When it is away from the transducer, it is negative or below the baseline. How you know it? Which I will just now clear. So this is known as a Doppler shift. Above the baseline is a positive Doppler shift. Below the baseline, away from the transducer. Now see the principles and directions of Doppler shift. Now you see, this is LV, this is RV, this is RA, this is LA. Now, many of you will be confused because you keep RV on this side. Now, once you are confused, now in a normal circumstance, LV is larger than RV. And this is the mitral wall between the LA and LV. This is the tricuspid wall between RA and RV, right atrioventricular wall. And you see, this is always attached more toward the apical side. Like the mitral wall we attach here, the tricuspid wall we attach here. So any wall which is attached more toward the apical side is the tricuspid wall, and tricuspid wall is always connected to the right ventricle. If by mistake you have inverted it, just see this. Now you see this. In a Doppler or in an echo, every time the transducer is being pointed from above downwards. So it is being pointed from, is always in every view, transducer is pointed from above downwards, like this, above down. So that the blood from the left atrium goes to the left ventricle. And because it is going towards the transducer, it will be above the baseline. So you see, this is the above the baseline because it is blood is going toward the transducer, which is pointing like this, a little bit like this or so. Any blood which goes away from the transducer is known as a negative Doppler shift. So here, this is the mitral wall. You see, this is the mitral wall, and this is above the baseline. This is the baseline. It is above the baseline because the blood is going towards the transducer. So very simple, but these are something difficult to understand for the first time. But if you regularly practice and see it, so this is like this. And I told you TR. I told you it is away from the baseline. A tricuspid regurgitation occurs from RV to RA. It is above the baseline, so it is it is negative Doppler shift. This is negative Doppler shift. And the one we showed you was a positive Doppler shift above the baseline because the blood is going towards the transducer. Further example, let us see this. Now, this is aortic wall. Now you see, this is systole. Now you remember that the horizontal line tells you the timing and the vertical line tells you the velocity. Now you see this is systole. The transducer, the Doppler has been put into the aortic wall, which is away from the transducer. So it is coming as a negative Doppler shift because it is blood is going away from the transducer. And this is diastole. This is any flow going from the aortic wall towards the transducer is the commonest cause is aortic regurgitation, and this is shown above the baseline. So if you see any Doppler like this, that means the one going below the baseline is the aortic flow which is going away from the transducer, and the flow which is going in diastole, you see this is going in diastole towards the transducer is the aortic regurgitation flow. So any doubt will just there will be more examples coming. Now, it is always the candidates have felt always difficulty in understanding it. So you have to really understand it and then also practice in your wherever you go. There are three types of Doppler modalities commonly meant for you: pulse wave, continuous wave, and a color Doppler or a color flow mapping. So these are the three types of Doppler modalities. Now forget about one crystal, two crystal, this is a continuous wave. This is something which is known as a sample volume. Wherever you put the sample volume, you get the velocity from the same place. If you put over the mitral wall, you will get the velocity only from mitral wall. You put it on the aortic wall, you will get velocity only from the aortic wall. And this is hence it is indirectly it is known as a range resolution, but this is this. There is no sample volume in a continuous wave Doppler. This one is transmits, one is received. Number two, this pulse Doppler records only low velocity flows, while this records high velocity flows. This is the 2D echo. This is the continuous wave Doppler records high velocity flows, and pulse Doppler records low velocity flows. If you just see CH, means continuous high velocity flows. To make it more simple, you see, this was I told you a range resolution. Yes. How does it look like in echo? You see this cut. When you see this cut, whose depth can be varied, this is like a pulse Doppler, and this is the sample volume. You see. So because and once you go, as I told you, in a pulse Doppler, you see it is a pulse. This sample volume is seen. But in a continuous wave Doppler, it is not seen because it's high velocity flow. When you see the difference, this is CW. Now this has disappeared. This has disappeared again. Now again I come to you. This is a sample volume which is seen as a sort of a horizontal cut. This is known as sample volume. Wherever you put the recorded, and this will suddenly disappear when we go to a continuous wave Doppler. So here you know, so that means there is no sample volume in a continuous wave Doppler. So we'll come back again. Now you see a Doppler modalities, a pulse wave records low velocity flow. Remember, a continuous wave Doppler records high velocity flow. Basic important thing. Its importance will tell you. A sample volume is present in a pulse wave Doppler, which we showed you. There is no sample volume in a continuous wave Doppler, which we showed you that there is no sample volume. And I told you that this measures flow at a specific site. There is something known as aliasing. That because the pulse Doppler records a low velocity flow, and whenever the velocities are more than say 1.5 to 2 meters per second, what happens? That you see this is a now this I first I'll tell you, this is a pulse Doppler. You see, I have put the pulse Doppler on the mitral wall, and you can see this is the mitral Doppler above the baseline. And this I showed you previously that you put the continuous wave Doppler on this and we recorded this velocity. So that means it requires a high velocity. Aliasing is this structure I'll show you. When the flow measures at a certain velocity, which is known as a Nyquist limit. Nyquist limit is the highest measurable velocity by a pulse Doppler, maybe 1.5 to 2 meters per second. And how does it look like? Now, this was a patient of a mitral regurgitation. We have assumed, so this is the mitral above the baseline, and we have purposely put a pulse Doppler because this mitral regurgitation velocity should be almost 5 meters or 6 meters per second. We have purposely put a pulse Doppler to show that the velocities are above and below the baseline. You cannot measure from where it starts, where it goes. For example, here in mitral Doppler, you can know it starts from here, goes from here, then comes back. All the measures can be done. But in a CW, in a aliasing, you see, you don't know it is both above and below the baseline. You don't know from where to get it. Now you remember, aliasing is of two types. It is a physiological or pathological. Physiological is, suppose you run or suppose you climb 30 steps, your blood through a particular valve increases and you get a slightly higher velocity flow, which is a physiological aliasing. Suppose a patient, you have done an echo, the patient develops an anemia. So with that, there's an increased flow through a valve that produces an aliasing. That is physiological, and pathological is a disease of the valve. So what about we? So that is a, for example, mitral regurgitation, aortic regurgitation, VSDs, and also that is the pathological aliasing, and this is a physiological aliasing, which is very mild type also. For example, you see, this is a mitral Doppler because again we have put a pulse sample here. It is above the baseline. The velocity is about 1 centimeter and 1 centimeter, 1 meter per second, 1 meter per second. Now this will be shown to you when you take this baseline above. This becomes 0.5 only from 1, and this becomes much increased also. So just remember, this is only we will told to you, will tell you when you move the sample volume, this baseline above, the velocity below increases. When you move it below, the velocity above increases. So just remember the basic. You'll make it more clear when a live demonstration is shown to you. This is what we usually do in physiological aliasing. You increase the velocity scale and you shift the baseline to increase the velocity so that your aliasing may become less. Otherwise, if this was in aliasing, you put a CW Doppler, the whole aliasing disappears. Because CW can record, you see, we say 5.7 meters per second, which cannot be recorded by pulse Doppler. So the whole aliasing disappears. So the simplest thing is, many methods will be shown to you, but the simplest is that when you see an aliasing, put a CW and the aliasing will disappear because it records high velocity flow. So why here? Because this can record a velocity of only about 1.5 or 2, maybe maximum 2, but 1.5 or so. But here the velocity is 5.7 meters per second. So you are hearing an aliasing, but now you don't see an aliasing. You see again, you see it is all recorded all along the line, wherever it is the dash CW here. You can see in diastole, you can see this is the mitral wall seen above the baseline, and this is in systole below the baseline. That means there is a certain structure flow which is going away from the transducer and in systole, and the most common is an MR. So that a CW Doppler will record the whole velocities along the whole path of the Doppler beam. So these are the basic differences. Again, just to tell you, these are the two most important are low velocity flow, high velocity flow, sample volume, no sample volume, aliasing, no aliasing in this. And that is shown here. So where do we use pulse Doppler? Wherever we want there are the normal or a small amount of flow. So this will tell you as the course advances, usually across some normal walls and some veins or so diastolic function. But for the time being, remember, wherever there is a low velocity flow, and number two, wherever you want a flow to be recorded at the precise site, that is the pulse Doppler. Suppose you want to record from a pulmonary vein only, if you put a CW, it will record along the whole line or so. So once you want to record a normal wall, or you want to record from a particular structure, it may be anywhere, that is a pulse Doppler. While a continuous wave Doppler records all high velocity flows. Remember, all disease flows are usually high velocity flows. All disease flows, like a stenotic wall, regurgitant wall, PA pressure, shunt flows, prosthetic walls, and many other things. So just remember one thing, wherever there is a normal flow and wherever you want to study a particular site, there you use a pulse Doppler, and wherever you are getting high velocity flow, you just go put a CW Doppler, because otherwise they'll be aliasing. Now, this type of slide you will get very frequently in your day-to-day work. This will be very important slide. Say every chamber has got an inflow and the outflow. Now, this is a left ventricular outflow. When the blood goes out of the left ventricle, a LVOT is formed by the anterior mitral leaflet, and this is the aorta. This is any valve structure connected to the aorta is the anterior mitral leaflet, and this is the septum, and this is the aortic valve. So this is the LVOT. So the LVOT is formed between the anterior mitral leaflet and this. Now you have to be as parallel to flow. That is why you tell this apical view, because the transducer is pointing above downwards or so. If you are asked about LVOT flow, always say apical 3 or 4 chamber view, and it is formed by the anterior mitral leaflet and interventricular septum. So that is why I said you must know what has been taught to you in the last week, then so that you can remember the structure. So because you want to specifically see the LVOT only, so you have to put a sample volume. Because you want to, if you put a CW, the CW will cover everything. ठीक चल रहा है? So if you have to study this, then you have to put a pulse Doppler here. And you see here, we have put a pulse Doppler. You see, this is a pulse Doppler we have put, and then we have recorded an LVOT flow. Now, because it is going away from the transducer, hence it is below the baseline. It is below the baseline because you have to, again, we have used a pulse Doppler. Then this is the baseline, and this is LVOT below the baseline because it is going away from the transducer. So the tips: use pulse Doppler in situations of normal flows. If aliasing occurs, whether it is physiological, pathological, revert to CW Doppler. Use CW Doppler in all disease states where high flow velocity is expected. Place sample volume at the tip of the leaflets. Suppose you want to study the mitral wall, tip of the mitral leaflets, aortic wall, tip of the aortic leaflets, tricuspid wall, tip of the tricuspid leaflets. So this is an important slide. Normal flows, put at the tip of the leaflet. If there is an aliasing, convert to CW Doppler and CW in all disease states. Now, one of the most important requirement in Doppler is angular dependency. You have to be as parallel to the flow as possible. If you try to be almost like a zero angle, If you are not, now you see, in a 2D echo, you get the best imaging when you are perpendicular to the flow. That is why you always get the best parasternal long axis view because you are perpendicular to the structures. But in a Doppler, you have to get the best results when you are parallel to the flow as possible. A maximum about 15 degree or 20 degree deviation is acceptable, but try to be even less than 15 to 20%. And whole Doppler results depends upon this. If you are not parallel to the flow, your velocity will be much reduced. So there are two basic dictums. In which view or views is this wall seen? You get it down now. Here your last week's lecture comes. That in which view, in which view or views is this wall seen? Am I parallel to the flow? So this is your basic 2D lecture which you did last time. Now you see, for a mitral ball, you see. Now, but I'm giving an example. This is a parasternal long axis view. Aortic wall, aorta, LA, mitral wall, LV, RV, interventricular septum. The transducer is pointing above downward from here. So the transducer is perpendicular to the flow. So and you want it to be parallel to the flow. That means a mitral lesions, we never use a parasternal long axis view because you just see this is the mitral wall and this is the transducer pointing downwards from here downwards. So, but it is now perpendicular, not parallel to the flow. So that is what we have to do is come to the apical view because here what is happening apical view because the blood is going toward the transducer and you are completely parallel to the flow. So that means this is done to see you are parallel to the flow. So, so one example I showed you that here you don't take because you are perpendicular to the flow and here you take because you are because here the LA, LV and transducer pointing downward, you put a color and you see the you are parallel to the flow. So this is ideal view, whether you take 4 chamber, 3 chamber, but not the parasternal view. Tricuspid wall, multiple views, it may be difficult for you today to understand, but remember, in almost about 4 to 5 tricuspid wall is seen will be told to you when you take any quantitative lesions or so. Now, one is this is the RV inflow view. This is the right ventricle, left ventricle, and because the blood is going toward the transducer, it is of a red color. So this you see. So this is one view you take for a this is the tricuspid wall, which is between the RA and the RV. Then you take a short axis view. Again, you see this is the aorta, pulmonary artery, tricuspid wall, and you are completely parallel to the flow. Here you see. And here you see a apical view, and this is a subcostal view. RV, LV, RA, LA, tricuspid wall, and you can see this. And here you see RA, RV, LV, you are completely parallel to the flow because transducer is here and you are parallel to the flow. So there are multiple, so we have shown you only 4 views for the tricuspid wall, wherever you will be parallel to the flow. This is the parallel to the flow, and in apical view, and in subcostal, there's a short axis, you are parallel to the flow. Pulmonary wall, there are many views. Again, you see, this is the short axis view, right atrium, left atrium, interatrial septum, tricuspid wall, RVOT, pulmonary wall, pulmonary artery, and here you see this is the pulmonary artery. You are completely parallel to the flow. So you can take a pulmonary wall here, and sometimes when you are more experienced, you can take from the subcostal view. So main aim is that in which valve it is seen view and am I parallel to the flow. Similarly, there are many views of the aortic valve which will be shown to you when you see when this chapter on the aortic stenosis is taken. But you know it cannot be a parasternal long axis view because you are perpendicular. It has to be some apical views and some other views also. Now, gradients, I have told you, gradient is a difference of pressure between two chambers. Now, whenever there is an obstruction to the flow, the chamber proximal to the obstruction has to increase its pressure. Let us say mitral stenosis. The stenosis is between LA and LV. So the LA has to bear more strain and the LA has to increase its pressure. So the difference of pressure between the two chambers is gradient. It can be peak gradient and mean gradient. Peak gradient is 4 into velocity square, as we told you, modified Bernoulli equation. But it is related to the amount of blood flow through a wall. Hence can vary. What I told you, if you climb 10 stairs, your blood flow will increase and your peak velocity will increase. Patient develops an anemia, it will increase. So it can vary on a day-to-day flow in this view, but a mean gradient is a average of multiple gradients, hence it is more reliable. So this is reliable in certain conditions like a pulmonary stenosis and aortic stenosis, but mean is available in all valves. You can accept pulmonary valve. You can see the mean gradient, which is an average. And average is always better than a single measurement. When you do an average of many things or so. For example, here I tell you that when you do a Doppler, we always measure 3 cycles. If you always see all the 3 will be different. So you can average of 3 in atrial fibrillation more. And the velocity time integral also you will be here VTI or TVI. Distance in centimeters, the blood travels in one stroke is in centimeters is one. For example, I'll tell you here, now you see, all gradients you can get by planimeting or tracing the wall. Once you trace the wall, you automatically get peak velocity, peak gradient, mean gradient, and VTI. So the VTI or velocity time integral is the amount that is about 23 centimeters. That means the blood travels about 23 centimeters in one stroke. So that if you are asked, how do you get the peak and the mean gradient? You say that now you see we have taken a pulse Doppler at mitral wall. Now taking this and you trace it. Whenever you trace it, you get a combination of these. If you don't trace, then you get individual velocity. You measure here and you measure there also. So that is how you get it. Now this is like a VTI. This is this left ventricle aorta. How much it travels in one stroke, and you see all of them are variable. So that you have to take an average. So if you see here you see all the 3 velocities have got a different velocities. So if you take only one, it may be more. So normally you see this velocity is less than this. So normally whenever you do a Doppler, you ask the patient to hold the breath, preferably in expiration. So then these variations will disappear. Now here you see this is less, this is more, this is stable, this is less. So always take 3 in a sinus rhythm, 5 in atrial fibrillation, and ask the. Now, surprisingly, sometimes your imaging is better when the patient is asked to hold breath in inspiration, but you take normally expiration, and whenever the Doppler is stable, put a sample volume, and then you see that how it goes or so. So basic difference between 2D echo and Doppler, the target is tissues, here the target is blood. Here you see the anatomy, size of the LV, size of the RV, IVS thickening, posterior wall thickness, thickening of the walls and whatnot. Here it is physiology, information, structural and hemodynamics. Alignment, perpendicular, that is why you get this, and this is parallel. And this gives a semi-quantitative and this gives an accurate estimation of this. Now control panels will also be shown to you. It is better you uh, keep in mind, and this will be properly shown to you. For example, this is high gain. There is an overall gain, and one is a TGC. Overall gain tends to increase the whole grain, and you see there is such a extra shadows and these are which are not good. And here it is too less also. So it should be ideal. And wall filter, you see here, you see the base is connected to the leaflets or so, and here you see there is a space. We have increased the gain. So I think we leave it till you get a live demonstration seen in these. So lastly, we come to color flow mapping. So you have seen pulse, you have seen CW. Now the main advantage of a color flow mapping is that you can see the blood flow. When the now suppose the flow is like this, you put it completely parallel. There was a stage, sometimes the blood can go in an eccentric phase, and you are going on struggling without a color flow mapping. So it helps a parallel to the flow. That is when you see the blood, and it gives an information within few seconds. According to the universal convention, flow towards transducer is shown as a red color, and flow away from the transducer is shown as a blue color. Now you see here. Now this is the transducer is pointing above downwards. This is the left atrium, left ventricle. The blood is going towards the transducer, hence is of a red color. And then this blood is coming out into the aorta. It is against the transducer direction, hence it is of a blue color. So you can very, very easily see that the transducer is always pointing from above downward, and the blood is going towards, it is red, going above, away is the blue color. On that basis, the laminar and the turbulent is, laminar is a uniform color, a blood with a uniform velocity and direction. Turbulent is a disease flow. Just remember the time being that laminar is a normal flow, it is a disease flow. Now, for those who keep RV on LV on this side, this is LA, LV. Now, this is the blood is going towards the transducer, which is pointing above to downward. It is of a red color. And you see here, the blood is going away into the aorta, hence it is of a blue color. Again, the same thing. Now you see it is such a sensitive technique. Now the red is the blood towards transducer, blue is away. Now you see a small jet of red here. This you see a small amount of red. This red means it is coming from the aortic wall. And because it is red, so that means it is moving towards the transducer and coming from the aortic wall during diastole. So that means it is a very trace aortic regurgitation. Now these are the turbulent flows. Nowadays you don't see a mosaic flooring. We have seen a color, a multiple, when the multiple colors are there. Till now you have seen a simple color, either blue or red. And when you see a multiple colors, that is known as a mixture of colors, that is known as a mosaic color or mosaic flooring or so. For example, you see here, this is a turbulent flow. And this is the mitral wall, turbulent flow across, going toward the transducer, and this is away from the transducer. So this was the case of MS and MR. The blood is coming away from the transducer, is blue color, but here you see it is a multiple color with outflow is only red, outer color because it's going towards transducer. So you can see always the difference between, again you see how this is a smooth color, red and blue, and here you see there is a multiple colors known as a turbulent flow or a diseased flow. Now this slide is not meant for you, but because it was here, you see this is the LV, this is RV, this is the mitral wall, and you see a blue color coming from the mitral wall. That is, the blood is going away from the transducer across the mitral wall. That is, it is the mitral regurgitation. The same blood with the LA, now it reverse, it changes direction, and when it goes towards the transducer, it is of a red color. Because the blood has to go out from the LA, so when it changes direction, it becomes a red, and this is the blue. Just because it was meant so that now again you can see turbulent flow in aortic stenosis, aortic regurgitation. So multiple colors you can see. The advantage is that suppose a patient has got a systolic murmur. Systolic murmur can be because of MR. Just giving an example, MR can be pulmonary stenosis, can be VSD or so, any of the thing. So you put a color in the pulmonary wall. If there is no turbulence, pulmonary stenosis is ruled out. Put it over the mitral wall. If there is a turbulence, mitral regurgitation is the diagnosis. So wherever there is a turbulence, you suspect of this. So if you are suspecting a 3-4 places, put the color flow there. If it is a normal flow, that the disease is not there, because it is again a normal thing. Now see, it is so sensitive that it has picked up of a trace MR which is not very significant. It is so sensitive technique. Again, this I showed you, and you see here, pulmonary artery, a small amount of red flow going towards the transducer from the pulmonary artery means it is a pulmonary regurgitation. Because the pulmonary flow is blue, so the blue, like an aortic regurgitation, when the red blood is going from the pulmonary artery, it indicates the presence of a PR or so. This is again not meant for you. This is a case of mitral stenosis. A jet, which is the two jets are seen. A jet which is going towards the transducer is of a red color. A jet going away from the transducer is of a blue color. Just because here, so I'm showing you, this is going towards transducer, away from the transducer. So the summary of the Doppler is, it provides a blood flow info. Now this also you can be, it will be told to you during the workshop. Provides blood flow information, correct? Because the 2D provides an anatomical information, it provides a blood flow information. Be as parallel to the flow as possible, not perpendicular. Now you see, this we told you in the first slide. Why now? You have seen the disease. Then you put the color to see where you have to put the Doppler. By color, you can see the turbulent flow, and you put a Doppler on that turbulent flow. So that is why the sequence is always 2D to see for any anatomical defects. Then put every segment is to be covered with a color flow. Once you have put a color flow, then this will help you in putting a Doppler being parallel to it, and you get a Doppler. Now the normal sequence is usually a pulse Doppler, the theoretical pulse Doppler, and then go to C Doppler. Say suppose there is uh, a normal valve or so, you put a pulse Doppler, but if you find a turbulence, then you put a CW. In disease states, you can directly go to continuous wave Doppler. So you have to be very clear about the pulse wave Doppler, continuous wave Doppler, multiple imaging planes, and to be as parallel to the flow as possible, and when to use the pulse Doppler and when to use this. So the pulse Doppler records low velocity flow. For velocity studies, keep sample volume at tip of the leaflets. A CW Doppler records high velocity flow, interrogate at the site of the turbulence. Scan all planes to get the maximum velocity. Never, sometimes you get the velocity in one, but because all your calculations depend upon the velocity, and you get all maximum velocity. Color flow mapping should cover all areas you can get a sort of a unwanted flows or so. And these are some of the normal velocities. Now, any clarification? Now, all these will be shown to you, but before that, what I suggest that whenever you come for any lecture, whichever lecture is there, read a little bit about it, so you are more clear what is being taught to you. So read a little bit about it also, and then, so I know it will be